And so let's get started. All right, welcome everybody. It is Friday, May 16th, 2025. Can't believe the year is going by so quickly. And we have a very full schedule. I think we're booked out for this webinar till October. So all the people you're seeing here in these weeks, we booked them months ago. And we have people who are now emailing us saying, hey, love to be on your webinar. So I think we're providing a great service. We have really smart, great people. And today's guest fits that mold, and he happens to be from Pittsburgh, my old stomping ground, and Paul's old stomping ground. Simon Taxel hails from Pittsburgh. He's a paramedic crew chief and public safety driver with the Pittsburgh Bureau of EMS. He's got education from places like Johns Hopkins. He's now in Pittsburgh doing amazing things. If you look him up on the internet, he's a writer. He publishes, and he's very heavy into a topic that all of us are very interested in. I know, Charlie Ingram, you're very interested in this topic, which is opioid use disorder and what EMS should be doing. And I was sent Simon's information by our good friend Hillary Gates, and Simon agreed to come on the webinar. So without any further ado, Simon, thank you so much for joining us today. You have a great audience here of EMS leaders, EMS medical directors from across the country. So my friend, take it away. Welcome.
Thank you. Thank you for the kind introduction. I'm thrilled to be here and to talk about this work. Being in these spaces is always incredibly humbling for me. I feel like I'm a lifelong student of our craft and our work. And so this is a wonderful meeting of the minds, and I'm humbled and honored to be here. I am a Bloomberg Fellow at Johns Hopkins University. I recently completed my master's in public health, and my focus there was addiction and overdose. And so I've been doing a lot of work in the intersection of public health and EMS and addiction and overdose. And I really think that it's a natural fit. And there's a ton of opportunity here to make a real difference. And so what I'm going to be talking about specifically is a bundle of care approach for the management of suspected opioid overdose. And this project was born out of a couple of things. One, I wanted to create a harm reduction informed, evidence-based update for our interventions as trained rescuers for opioid overdose. And then also it reflects the changing nature of the toxic drug supply locally here in Pittsburgh. You guys can all see my screen, correct? My slides? Perfect. Here in Pittsburgh and across the nation, there's an ever-changing list of adulterants that are being found in the supply of injection drug use. A few examples are listed up here on the screen. Notably, MPS, we're seeing a lot locally. It is, I believe, a plastic stabilizer from industry. We don't know a whole lot about it. It was never been intended for human ingestion, so there's no real studies or research on what it does, but we do know that it's a potent calcium channel blocker. And so there's the nature of our response to overdose is changing, both because of the adulterants in the injection drug supply, as well as the fact that at least here locally, that we have a very, very robust infrastructure for the distribution of naloxone in the community, which I think is incredibly valuable and important. But it has changed as EMS clinicians, our response to overdose, in that most of the time when a patient just needs a little intranasal naloxone and then they return to baseline functionality, there's never even a 911 call placed anymore. The patients that we see are those that have experienced polypharmacy overdose, are experiencing the deleterious effects of all of these other additives in the supply, or have experienced anoxic brain injury or other profound medical complication. For example, just 2 days ago, I was on duty and attended an overdose. The patient had received intranasal Narcan prior to our arrival, and his respiratory rate his breathing was more or less okay, but he remained unresponsive. and had a heart rate of 40, which didn't react to atropine at all. And so we ended up just giving him oxygen, monitoring him, prepared to intervene additionally with the airway as needed, and then transporting him. So the idea in this bundle of care is to not only provide a compassionate and evidence-based response, but also provide a response that's informed to the changing nature of the overdoses that we see as EMS clinicians. We've adopted it as our standard of care in the Pittsburgh Bureau of EMS, and I'm currently working with the leadership at the Department of Health, and I'm hopeful that this will be included in the Pennsylvania State ALS protocol in its next iteration next year. So just to talk about what we have been doing, the standard care focuses on IM, IN, or occasionally IV naloxone. It's in the hands of first responders, police officers, bystanders. Positive pressure ventilation and BLS airways are obviously part of what we do. And our bundle of care doesn't really change much of that. It just has different points of emphasis. And then I also do feel the need to note that we're seeing a significant increase in the use and the advertisement of high dose naloxone products and other alternatives to naloxone for the reversal of opioid overdose. And these are not evidence-based interventions. They're being sold to well-meaning politicians and public safety officials, but at the end of the day, they're going to do far more harm than good. I'll talk a little bit more about that as we move through. But there is no evidence that suggests any of the high dose naloxone products actually make a difference, even in an age of synthetic, highly potent opioids like fentanyl. So we'll get into this. The complications that we see in the field, in particular when patients receive large doses, multiple doses, or high dose naloxone, is agitation, nausea and vomiting, and precipitated withdrawal. And at the end of the day, I've been in EMS for 21 years now. I want to do what's best for the patient, but I also want to do what keeps things smooth sailing for me and keeps things easiest for me. And I believe that managing a patient who's overdosed and not causing them to have nausea and vomiting, not causing them to experience agitation that I then have to go and sedate them again, not causing the agony of precipitated withdrawal. Not only is it better for the patient, but it is better for the EMS providers as well. And so we'll get into this bundle of care. This slide may be a little bit small to see, and we're going to break it out, but this is how we provide it to our members. And in my mind, the difference between a protocol and a bundle of care is in the care bundle, all steps of it are important. And instead of moving through something like step 1, step 2, and then maybe we stop because the problem resolves before we get to step 3, or our protocols tend to provide a roadmap for escalation. And when we get to a point where the problem is under control, then you tend to back off. Whereas with a bundle of care, we want to provide all 4 steps in this case, even if the patient starts to get better. Not a huge difference, but to me, it matters. So step 1, this is the most important part of care for patients who have experienced opioid overdose. And it's really back to the basis. If the patient isn't breathing well, then we place a BLS airway and we breathe for them. This is the life-saving intervention. Naloxone in the hands of the general public and lay rescuers and people without training and equipment is a life-saving medication. But in the hands of trained EMS clinicians who have access to oxygen, BLS airways, and BVMs, the BLS basic care and the oxygenation is the life-saving intervention. And so this step 1, not only does it emphasize providing oxygenation and ventilation prior to any other intervention, it's time bound, and we want to see our clinicians arrive on scene and immediately identify that this patient has respiratory insufficiency and manage that. Step 2 is that we would like to apply all our monitoring. So we're bagging the patient. We have BLS airway in, then we get them on our monitor. We blood pressure, SpO2, EKG, as well as nasal and tidal CO2. And what's really important here is that we want to mitigate hypoxia and hypercarbia prior to any further intervention, if possible. It is my opinion, and I'm hopeful to start to collect data and actually be able to validate this scientifically. But I believe that a large portion of the agitation and the symptoms that we see post overdose reversal have more to do with a patient who is waking up profoundly hypoxic and hypercarbic. And I believe that correcting those two things prior to administering naloxone will allow us both to give the minimal effective dose of naloxone and will help prevent those unintended consequences, those untoward events that we talked about prior. Once that we've corrected the patient's vital signs and normalized their vital signs, then we start to think about naloxone. And our recommendation is to establish IV access and give low dose 0.4 milligrams of naloxone IV. We believe that this is the most effective administration route of naloxone at the lowest possible dose, which is, again, good for us and good for our patients. We see tons of patients that have had many, many doses of naloxone from bystanders and first responders before we get there. And what we found is that if they've received multiple doses of naloxone, and then either we don't need to give them any more, because it's like the patient I saw this week who has other things going on, or they are going to just wake up once we normalize their vital signs. So we're telling our paramedics and EMTs and advanced EMTs, if they've gotten more than one dose of naloxone prior to us getting there, then at most we're going to only give them one dose of naloxone. If they haven't had any, then we're going to give them 2 doses of naloxone total. I am confident that with the appropriate management of the airway and ventilation, the normalizations of vital signs, no matter what opioid the patient has ingested, 2.4 milligrams of doses of IV naloxone will be more than enough to reverse any overdose. And so this also codifies in the bundle of care three points of emphasis that the goal of naloxone administration is the return of spontaneous respiratory drive, not ambulation, and not even necessarily the return to consciousness. It's if we want our clinicians to look at the patient in total and understand that if the patient is unresponsive but breathing normally, then their problem isn't opioid toxicity, right? Their problem has to do with other derangement of their vital signs or other ingestion. There is no evidence that increased doses of naloxone are beneficial, no matter what the patient is ingested, including fentanyl and other synthetic opioids. This is, I think, a pervasive myth among pre-hospital providers and probably among healthcare providers more broadly, that in the age of synthetics, we need more naloxone. And what we do know is that the more naloxone a patient receives, the more likely they are to experience precipitated withdrawal and other adverse events. And so we're really hammering this point home that more naloxone isn't the answer. So if the patient doesn't return to baseline consciousness, then we're going to provide supportive care, monitoring, and transport to the ED. And then if the patient does regain consciousness and wishes to refuse, then we'll move, or even if they don't wish to refuse, if when they return to their baseline level of functionality, we have the opportunity for doing our harm reduction outreach that includes leave behind naloxone. Those packets now include fentanyl and xylazine test strips. We have an opportunity for a warm handoff to the UPMC Addiction Medicine Clinic. We're lucky that in we've worked with our poison center and Dr. Michael Lynch, and we can call a 1-800 number that is attached to the Pittsburgh Poison Center and get an immediate appointment at UPMC Addiction Medicine walk-in clinic within 24 hours should the patient want to do that. And then we also have buprenorphine available. That program is, we've experienced some challenges with it. We follow a standard 16+8 dosing structure that was developed when the opioid supply was actual heroin, and it just doesn't work as well with fentanyl. And so we've seen patients experience precipitated withdrawal from that uh, that dosing structure. And then also there's lots of people who use drugs who have had precipitated withdrawal associated with their fentanyl use. And so I've seen numerous patients that were experiencing symptoms of withdrawal, but had no interest in the bupe because their past challenges with it. So it's been complicated, but we're still working on that. And so these programs have been part of what we've been doing at Pittsburgh EMS since 2017. But I think getting this into the Pennsylvania Advanced Life Support Protocol and including the provision of these harm reduction measures and in a statewide protocol is an important step in normalizing this sort of care and outreach in the EMS environment, which I think is absolutely vital to our mission of saving lives. And so just to recap, why are we doing this? It's providing a comprehensive standard of care from the moment of patient contact all the way through transportation or refusal or warm handoff, depending on the patient's needs. It prioritizes oxygenation and BLS airway management as the primary life-saving intervention. And just so there's no confusion at all, I am 100% in favor of anyone in the community, any bystander, any person who wishes to have access to naloxone to give to anyone they encounter. I want there to be as much naloxone in the community as possible. And the recommendations as far as oxygenation, airway management, and those things are we have to track our response for EMS clinicians that have equipment and lay rescuers that don't have equipment. So I am not arguing for any changes in the way we train lay rescuers to give naloxone. This is specifically for EMS clinicians with equipment. And then I believe that the normalization of vital signs prior to the administration of naloxone helps to facilitate reversal with the lowest possible doses. And in total, this will reverse the adverse events that we see, and then make my job easier as a paramedic working on the street, and as well as improve outcomes for our patients. We want to address the complexity of the problem that is associated with the high level of contamination in our illicit drug supply. We want to reinforce that low-dose naloxone, especially when given IV, is sufficient to reverse the overwhelming majority of overdoses. And we want to institutionalize and codify the provision of safety and recovery resources as a vital part of our role in the community as EMS clinicians. And so that told me to take 20 minutes. I know I ran through this pretty quickly, but I think I kind of hit it on the nose. I look forward to any comments, questions, or discussion, and then I'll just leave this up here with my contact information for anybody that would like to reach out by other means.
Awesome, Simon. That was incredible, and there's a lot to talk about. I know there's a lot of people on this call who have programs, who are thinking through this. We've had to go through some of the media hype and modifications based on what we're hearing, but I did have a few questions because I'm fascinated by this. First of all, I love the bundle and the fact that you say at the very top, like it's all about the airway, folks, right? That's the most important thing, rather than people reaching for the naloxone without even considering doing the primary airway assessment, etc. The question I have for you is the following. It's, I'm very curious about this 0.4 milligrams and then one more dose of 0.4 milligrams. And my question is related to outcomes. And I wonder, have you been able to follow your outcomes in Pittsburgh to show that this protocol is indeed providing good outcomes, that indeed you don't need the mega doses of Narcan, which many people are using, unfortunately. And so I just, if you could start by answering that one, and if you do have the data, would love to see the publication on that.
We're still in the early phases of the implementation of this, and so I certainly aspire to get to the point where we can collect data and validate this through evidence of practice. I know that there is some studies going on about the number of doses of naloxone that and what the routes are getting and how much they're getting. Where Chris Martin-Gill and I believe it's the Red Door study, we're part of that, and so that data collection is going on independent of this project. But I certainly aspire to convince all of my colleagues that this approach is the way that we need to be doing it. We have found when we try and change the way that care is provided substantially, it takes almost 2 to 3 years to till we can get all the clinicians in our system to do it the same way. What we saw when we developed and implemented the now famous or infamous Pittsburgh EMS crashing patient protocol that is now, I think, spread across the country. It took us 5 years of working with our clinicians to change that mindset of, we see a really sick patient and now it's time to load and go and get to the hospital, to unless there's a stroke or trauma or something else that's immediately time sensitive, but to manage the airway and treat medical shock prior to patient movement. And so it's maddeningly slow, but we have to accept that in reality incremental change is the way to go. So it's going to take us some time to get all of our clinicians on board with doing it this way, and then we'll have to do some data collection, but I certainly hope to have that evidence for you.
Great answer. And before I bring my associate medical director, Charlie Ingram, in, because he's got a lot of experience with this, I'm wondering, are you getting any pushback from the docs in the ED? I mean, I work there. I know these are high flying docs are great. Are they saying like, what's going on here, or are they also on board with the 0.4 and stop?
I think that they're on board with it because we're bringing in patients where we have objective data that this patient may still be unconscious and their heart rate's 40, but they're breathing 16 times a minute. They're on my monitor, and with end tidal, their end tidal is 30, and their pulse ox is 100% on low flow O2, and so that to me is a really objective finding that more naloxone isn't warranted. I did just, it was interesting. I was talking to one of the residents on the case that I just was discussing, and they had no idea about the level of contamination in the drug supply locally. And so I took out my phone and I'm showing them Prevention Point Pittsburgh's Instagram page, where they post qualitative analysis of local stamp bags every week, and saying, so okay, so we found a blue bag with a blue stamp on this patient. And while we can't say for sure it's the same thing, they said on Tuesday that they found blue bags with blue stamps that have BT MPS, medetomidine, procaine, lidocaine, xylazine, and fentanyl in them. And it was a really great kind of interaction, where they started to expand their thought process of how to manage this patient immediately. And I think that we have a really wonderful relationship with all the doctors and residents that we see here in Pittsburgh. And I feel very, very, very respected, and people listen when we talk about what we're doing with our patients, and especially when we can back it up with really, really high end care. And so some of the physicians may not be as knowledgeable as others, but I personally haven't had any pushback.
Okay, excellent. And we're going to get to some of the comments in a minute, but let me go to Charlie. Dr. Ingram, you practice up in New Haven, Yale. You were at Cooper, New Jersey. A lot of experience. What are your thoughts on Simon's talk?
Yeah, so awesome work overall, Simon. So it's super interesting. I have received tons of patients with opiate use, and intox as well as like over like toxicity, and have seen a ton in the field, right? So Cooper had a system where like the number one dispatch was unconscious and the number two dispatch was overdose. They were all overdoses, right? And so they got really good at this. I know that Cooper is doing a study right now in the ED to look at initial dosing of buprenorphine. We had a similar kind of bundle there, and we called it the bupe bundle, and it was very bupe heavy and bupe first type of kind of push that we were doing there. But it was interesting. Like when I started residency there as an intern, they had just started the program. And by the time I finished residency, I went to an overdose with EMS and with the EMS physicians there. And a bystander had already given 4 milligrams of intranasal Narcan and then followed it with 16 milligrams of home Suboxone. It was mind blowing. We're like, what what do you want us to do now, right? It's super, super interesting. And I think the idea of Narcan and the naloxone dosing is super important, right? Having different goals is extremely, extremely important. And I think the lowest possible dose to like have somebody breathing on their own is the most important, right? Very different than the 4, 8, 16 that we got to very quickly, with cops and bystanders and everyone else. And I think it's also equally important to have the tools necessary with medics, on the street to say, great, we've gone just over that tipping point, and now there's a lot of vomit everywhere. This guy's real angry, and he turns out to be bigger than me. And so, like, we have an option to treat that syndrome, right? Like, we should treat withdrawal syndrome as a complaint by itself, separate from the overdose. So, the only other thing I would add that I do often as a relatively busy emergency department, is I let patients titrate their Narcan, right? And that sounds difficult, right? But oftentimes what I do is I take 2 milligrams of Narcan, and a couple cc's of saline, and I put it in a nebulizer. And I tell the patient, I was like, look, wake up for 10 seconds. You're not hypoxic. You don't need real Narcan dosing, but you keep nodding off and you keep going like just slightly apneic, and then you wake up, and then slightly apneic and you wake up, and they're like, yeah, I don't feel good. Okay, great. Here's this mask. It's Narcan. I don't lie to them, right? Like, say it's Narcan. When you feel like you don't need it, just take it off. And then when they fall back asleep, somebody puts it back on them, and etc. Right? Super important that they have an end title and all of the monitoring that we have, but a nice option for like very gentle Narcan, and for patients that need it that don't have a medic of a 1-to-1 medic to patient ratio, which is nice. So yeah.
And Charlie, you bring up a great point, and I want to bring some other people in here because that's another flavor of giving Narcan. You see in the comments from Dr. Augustine, and then Hillary Gates posted some research that this is really up in the air. I can't imagine that everybody is doing the same thing. But before Dr. Pepe goes to his webinar, Paul, you have any comments on Narcan in general, this bundle of care from Pittsburgh?
Well, yeah. So you remember we did this paper with the Eagles about 7 or 8 years ago where we recommended this and try not to necessarily have to wake everybody up. And one of the reasons why is that this ain't your father's grandfather's heroin. There's so many mixed drugs in there. And one of the things we said was the B, N, and E. So consider breathing, consider Narcan, consider EKG. And so you get a better tracing and you know what's going on if they're not woken up and agitated and so on. So just one little pearl to throw into that to help support what we're hearing today. Okay.
Perfect, perfect. And let me bring in Dr. Greenfield. So Brett, I see you on camera. Thanks for joining us from New Jersey. Any thoughts here? What's your practice? There's got to be somebody here who's still at higher dose Narcan. What say you,
Yeah,
Dr. Greenfield?
Peter, an awesome talk, Simon. So we many years ago, when we obviously have a lot of issues in South Jersey as a result of our colleagues in Camden and the greater Philadelphia in reference to it just makes it's Southern trek. So eventually it hits us, and I took a hard position several years ago, and kudos to Pittsburgh for doing the same thing of limiting our ALS doses of IV Narcan to 0.5 milligrams, just because it was easier. And the goal was just to let folks breathe. Because these insane Hulkamaniac folks who wake up after large doses of Narcan, right? The running joke with our law enforcement heroes is for every police vehicle that is there, the patient probably received 8 milligrams of Narcan per vehicle. So if there's 3 vehicles, just do the math, right? And then the patient's still not breathing. One of the things that we are considering now, though, is because I think airway management and BLS is so important. We're starting to see some nitazine, issues with contamination, which is another synthetic opioid, created in the 1950s that's reared its head. That I think in some literature says it's about 500 to 1,000 times more potent than morphine, is including, just a basic face mask that can go with our Narcan leave behind kits. Something to think about, right? Easy to train, common folks on how to do that. I don't know who's going to do it and, how much reluctance there will be. But I think the reality is there's no easy recipe for this, and trying to keep up with what's contaminated, what's not, it is an absolute nightmare. But if you concentrate on the basics, basic life support, give enough Narcan for patients to breathe. I mean, we had a toxicologist here who said that we were insane for giving 0.4 or 1 or 2 milligrams of Narcan. He said the data said it should be 0.04 milligrams
Right.
of Narcan. So, again, kudos to Pittsburgh. I know there's no recipe for this, and this challenge will never go away, but I think we need to kind of think about moving a little bit away of this harsh Narcan approach and more, kind of an airway focused approach.
But Brett, this wouldn't be a good webinar unless we had a difference of opinion here. So let me bring in Dr. Augustine.
Yeah.
There he is. Okay, perfect. Jim,
Hi.
talk to us, because I saw your comment. I want to hear your comment.
Yeah, so I'm going to remind everybody that many of our illicit drugs have a regional flavor to them. And let's just imagine, the Dayton, Ohio, Cincinnati, Indianapolis area in 2016, 2017. And in those days, we had a lot of Narcan being given because it worked and we weren't getting effect. All of my career in Dayton, Ohio, we were using 0.4 to 0.8 as wake-up doses for our opiate use population, and it was working effectively, and we could titrate it up slowly, and everybody was trained in how to do that. And then we're faced with a different mix of our opiates. Many of the opiate overdoses, whether successful or not, if you will, that we were trying to resuscitate were not intentional. These were people that had no history of opiate use, and many of them didn't want opiates. And our formula was 2, 2, and 2 milligrams of Narcan. We felt that the police doses had very little to do because they are squirted erratically around the nose, let's say. And so for a patient that hadn't received law enforcement intervention, the formula was 2 in the nose and then 2 intramuscular. And then another 2 that was available to be administered, preferably IM, but potentially IV or another in the nose, depending on the patient. Many of those patients thought they were abusing another substance like cocaine or one of the other party drugs, and so we had a flavor in our region, which is probably due to a Chicago manufacturing base and the mix of opiates. We should be very, very careful about saying we have evidence that something works in our area is going to work in some other area, or criticizing those in other areas who have a different distribution. So that would be my contribution to the discussion.
And Simon, I'm going to give you the last words. You can respond to everything. I know we're a little over time, but I'm going to try and stream Tanner Smita, who's my co-host here, who, by the way, is getting married tomorrow. That's why he's not here. So you can all send him best wishes for his upcoming wedding tomorrow. But, I know what Tanner would say. He would say, we're giving hundreds of thousands of doses of Narcan every year. To Jim's point, we can localize it to a community. To Sam Neglia's point, we can localize it to a certain drug type in that community. And we can match it up to the Narcan dosing that's being given at that community and then tied to outcomes. Because really, as a medical director, I would like to see the entire continuum of care, to know that 0.4 and 0.4 in Pittsburgh, because they have that drug, in their community, is maybe not waking everybody up, but everybody's living and everyone's doing well and there's no untoward outcomes. versus potentially someone giving 8, 16 and some obscene number, and maybe it is causing pulmonary edema and maybe other bad outcomes, and people are getting punched and spit on and hit, etc. Wouldn't that be nice to know? So I'm gonna have you ingest all the comments you just heard and give you the last word, Simon. And again, thanks for coming on the webinar.
Oh, thanks for having me here. And yeah, all the points are well taken. Shout out to Cooper and their program in New Jersey. They were the first EMS Butte program probably in the world, and that's what we built our program on. So they're leading the way on that. And there absolutely is a significant amount of regionality in the drug supply, and that absolutely has a significant impact on the management. But I will say that no matter what is going on when it comes to overdose, if you're managing the airway, providing oxygen, and monitoring vital signs, you're solving the problem. And so that patient, if we had 5 hours to just bag them, right, then we could just bag them, and they wouldn't need any other intervention, and their survivability would be just the same. So again, it prioritizing that as the number one step is it helps to address that regionality and that difference in the drug supply. I think in the early 2016, 2017, all across the nation, we were giving lots and lots of naloxone. That's when fentanyl really hit us, and we all thought we were doing the right thing. And I don't know any of Dr. Augustine's services, any of his clinicians, or the medicine that they're practicing. And so this is not meant to be any sort of shade towards them. And I'm speaking of my own experience, the things that I've done and the things that I've personally witnessed. But back then we were prioritizing giving naloxone. And so I don't think that we were doing as good of a job at ventilating the patients and giving them oxygen. And so just because the patient received high doses of naloxone in the field and had an outcome doesn't necessarily mean that they needed it. And I think that when we were giving naloxone first, before we were managing the airway and oxygenating, it led to higher doses of naloxone before the overdose was reversed, because we weren't solving the main problem first. And so again, I'm not saying that's what's happening or what Dr. Augustine is reporting. That's just what I did and saw myself. And so I think we need to really be cautious and understand when we're looking retrospectively at what we did and what the outcomes were, did that necessarily need to happen? And then also, if your community and the overdoses you're seeing are people who aren't habitual opioid users, who have a different substance, maybe a sympathomimetic like cocaine, no matter how much naloxone they receive, they're not going to experience precipitated withdrawal. And so the high dose naloxone is probably much less dangerous and much less harmful in that patient population, because they're not physiologically dependent on opioids, which is the root cause of precipitated withdrawal. So it's just some things to think about, but the points are all well taken, and I certainly appreciate the opportunity to be here.
Excellent. What a great way to end it. Again, thank you everyone for the comments. This was probably one of the maybe the best conversations we've had around the topic, because it is something that not many people understand and know. So Simon, thank you for all your work. You clearly are passionate about this topic. Keep writing. I love your writing. Keep getting on podcasts. I know you speak as well. Appreciate Hillary Gates for sending you to me. And we here in the Florida EMS Webinar thank you for all the work that you've done. So the link is in the side for Dr. Pepe's webinar. I'll stick around here for a few more minutes for those people who want to continue the conversation, but please go over to Dr. Pepe's webinar. And again, thanks everyone for joining.